Thank you, Angela. Thank you, Rod. I'm obviously flattered to be here and thankful to the Seattle Science Foundation for this opportunity. And following Rick, believe it or not, that's a pretty hard job. He just knocked it out of the park. And so I'm excited to kind of piggyback on that. I want to start with what we're talking about, though. This is a fairly prototypical patient for me. I want to pay homage to kind of the people that taught us how to approach these patients. And so Dr. Arlet is obviously part of that. And I think the French gave us a lot of the principles for deformity correction. There's a 62-year-old female, left leg pain more than right leg pain, but you can see that she has a coronal and a sagittal balance issue. And so I'm a surgeon. I came from an academic background, but then retired from the Navy, ended up in a small surgeon-owned hospital that has 48 beds and 10 ORs, and I wanted to continue doing academic-type medicine. And so the problem that I encountered is, in this new environment, is there a way that I can take care of this patient without having to send him over to my colleagues here in Seattle so that they can be taken care of? Well, the French have given us the principles for deformity correction. They've given us something far better. This is a rider in the Tour de France, which is happening right now. And if you were to flip on your phone, you'd see that they're climbing the Col de Tourmalet today. So as soon as we finish up here and I jump on the airplane, that's all I'm doing from here on out is watching. But this is a specific rider that I want to focus on for a second. In 2012, now Sir Bradley Wiggins and folks from Team Sky set out this plan as British cyclists that were always strong on the track, but never strong at the Tour, right? The French probably didn't like the idea of the British invasion at the Tour, right, Dr. Arlet? And they wanted to approach it very differently. There was a very traditional approach to the Tour de France, and when these guys came in and said, we've got this new approach, we're gonna try to win the Tour de France in the first year of Team Sky, they were laughed at. And what they adopted was this idea of marginal gains. So while today may be a bit of a robotic talk in regards to deformity, really it's a talk on marginal gains and how we utilize these principles in deformity correction while respecting those same principles that allow for that. What's interesting is they brought in coaches from swimming, they brought in coaches from weightlifting, they brought in nutritionists, they brought in all these non-traditional cycling background folks and said, what can we do to optimize performance? And they utilized all those opinions and all those ideas, and the result was right here. So the first year of the Tour de France, Bradley Wiggins crosses the line on the Champs-Élysées wearing yellow. What's interesting is if you see the person right behind him with his head down, that was one of his domestiques that worked very hard that year. That guy's name is Chris Froome. He won second that year. So Team Sky won first and second. And then Chris Froome went on to win 4 more Tours de France after that. And so this is a strategy to the Tour that has now been adopted by almost every team out there. And so when we look at adult deformity correction, I think this is a little bit the Tour de France of spine surgery, right? So we looked at some of the things that Rick just taught us and these approaches to degenerative care and these pearls and techniques, right? How important is it for us to adopt these pearls and techniques from maybe non-traditional deformity backgrounds so that we can provide this type of care in a way that we can revolutionize the outcomes associated with deformity surgery, right? And so this is a little bit about, why we do deformity surgery, et cetera. This is really, and up at the top it says, can robotic assistance replace that with any new technology? Can any new technology help me accomplish my realignment goals in a tissue-friendly way? But then the second bullet here, the goals of deformity surgery, powerful correction, fusion so that we don't see worsening of that deformity, and adequate decompression to deal with the patient's actual symptoms, right? These are the principles of deformity care. Are there ways that we can deliver this better? And so what we decided to do, and this coincided with our adoption of robotic use at our institution, was to look at the first 50 cases that we did with the robot. Our primary outcomes were the correction, obviously our pre- and post-operative radiographs, as well as patient-reported outcomes, and then following these patients for some time afterwards. And so we began collecting in July of 2019. This is May of 2022. That's a typo, excuse me. It's May of 2021. We completed our first 50 deformity cases with robotic assistance. And while the robot and the adoption of the robot was what kind of inspired this, there were several other technologies that we relied upon to get to the end game. So the idea of those marginal gains, right? And so we approached these patients in a 2-stage fashion, in which the first stage was an anterior column reconstruction. And typically from L4 to S1, we would approach the spine anteriorly through a retroperitoneal approach with one of my general surgery colleagues. And we've seen in recent literature literature the importance of restoring our sagittal alignment, especially in the L4 to S1 segment, and getting almost 40 degrees of lordosis. And that really makes the rest of the case easier from a sagittal rebalancing perspective, right? And then approaching from the side for a strong coronal alignment, and through 2 incisions, I can usually do lateral lumbar interbody fusions at L1-2, L2-3, and L3-4 with a retropleural approach, often at the L1-2 segment, okay? And this allows for indirect decompression of the neural elements through segmental correction and restoration of normal spinal anatomy. And so in this particular patient, again, the one that I flashed up at the very beginning, we decided to approach them with technology available to us that would allow us to 3D print the inner bodies to account for bony loss that she has as a result of her deformity. And so you can see here a artist depiction, or the app in which allows us to see what our correction is planned with these 3D printed devices. And then at L4-5 and L5-S1, we use off-the-shelf anterior lumbar interbody fusion devices held in place with anchors. And so you can see the result on the CT scout image after stage 1, right? So we get a reasonable coronal correction, and with the aid of them obviously lying flat on the gantry and our anterior column reconstruction, a very good sagittal rebalancing. And if we look at these specific interbodies, you can see on the intraoperative CT scan, meaning between stage 1 and stage 2, which we use for our robotic planning, that these tend to fit the patient very well, the contouring of the undulations of the end plates, so that we get better contact, hopefully with less subsidence and other issues associated with off-the-shelf devices. This is another example of a similar patient, but the importance between the 2 stages, and the reason I still divide it up, is the importance of the physical examination and interacting with the patient. This patient that we started out with had left lower extremity pain. I need to know whether my indirect decompression was adequate enough to take care of that. And I judge that based on my intraoperative CT scan, where I can look at the anatomy, and then by careful physical examination of the patient. And if they wake up from surgery and they say, yeah, my left L5 radicular pain is gone, then I know that I've accomplished through indirect decompression one of those goals of the deformity correction. And so our second stage, we've already determined based on our CT scan, et cetera, whether I need to do any mini-open decompressions, whether any osteotomies would be beneficial for the patient, but typically I will do a midline incision. I will clean off the fascia bilaterally, and in this picture here that we see on the left-hand side, the midline is actually on the left. I've opened up a small fascial window where I've decorticated the spinous processes down to the spinolaminar line. We've inserted our biologic from essentially T10 down to L1, because I have biologic already in the anterior column from L1 distally, and then I close that back up at the very beginning of the case. I usually do this before I even do robotic registration, so that I'm not knocking off my registration by doing this portion of the case. And then we proceed with placement of screws, et cetera. The biggest advantage for me, and Dr. Chewett touched on this as well, with robotic assistance, is the idea that I can pre-plan. The amount of time that I can spend preparing myself for this tour de France, so to speak, of spinal surgery, in which all I have to do on the day of surgery is show up and execute, is invaluable to me. And all of this is done before the patient is asleep and bleeding on the table. So I can sit there and I can plan the procession of screws. It makes it far easier for me to do my per-fascial rod passage. So again, I'm passing the rod subfascially. And if I have a nice cascade of the screws, that becomes much, much easier. And this becomes a game of, I don't need to pass the rod, say on the right side, from T4 down to S2A, our iliac screw. I need to pass the rod from T4 to T5, and then from T5 to T6, and then T6 to T7. You take it segment by segment, and it becomes much easier, especially with the anatomic placement of the screws. And so you can see here, here's a difficult L2 pedicle that with robotic assistance was made a little less hair-raising. And it gives us our opportunity to sort of maximize otherwise disadvantageous anatomy so that we're able to aid with deformity correction. And what's been interesting to me, and we'll talk about in the results, is that I have not had screw pull out at all since we've adopted these strategies. And I think it's because we approach each of these pedicles with the axial alignment of the intended instrumentation. And once that instrumentation is in place, the bony interface is so good that it allows me to derotate the spine in a way that we don't lose that fixation. So I slowed this down a little bit so you could appreciate kind of the intricacies of what we're doing in the OR. But this is a T10 to ilium, obviously on a time lapse. The reason I like it here is you can actually see the efficiency of placing those screws. I'm not going from one side of the patient to the other. My PA there that works with me knows exactly what she's doing. Our back table knows what they're doing. And we're able to approach this at the very end. We'll put in our iliac fixation. And you can see the entire case done. This is about 35 minutes. total, and we get our T10 to S2 alar iliac screws in place in an anatomic trajectory. So this is back to our patient. Again, 2 stages. In stage 1, we did our anterior column reconstruction with about 100 cc's of blood loss. OR time was about 3 hours and 30 minutes. Stage 2, 800 cc's of blood loss. OR time was 5 hours and 48 minutes. This was 2 captures. The discharge to home, postoperative day 4 after cleared by physical therapy. And so how does this compare? If we look at those 50 patients, we can see our average age was about 70 years old. We had 64% female. BMI was in the 30s. First stage, you can see the time range associated with that and the estimated blood loss associated with those stages, all right? And then our correction, in general, we corrected our PI-LL mismatch from an average of 20 to an average of less than 10 with good confidence intervals. And then you look at the patient-reported outcomes, starting with a preoperative VAS of 6 and reduced to 2.7 at the latest follow-up ODI of 47%, reduced to 31%. And here are our complications. Of our complications, we had about a 12% proximal junctional failure rate at the 2 years of maximum follow-up. Again, following these folks over time, I think that rate is going to continue to go up. But I attribute some of this to the idea that we're getting such an aggressive correction down low that it puts less strain across the top of the construct. And we can see one patient succumbed to COVID and at 17 months of follow-up, so we didn't get to continue to follow her. But if we compare and contrast, Dobbs and Lanke, this is 2007 data, so maybe a little bit antiquated, but they looked at 46 patients with a standard 2-stage approach, all posterior average blood loss of about 2,000 cc's, 13 days in the hospital, and operative times of 10 hours. If you compare and contrast, we were able to do more levels with an average blood loss of 267 combined, mean length of hospital stay 5 days, and combined surgical time about 6.37 hours. And actually that bottom bullet, sorry, right here, no transfers to other hospitals. So again, we're in a surgeon-owned hospital with 48 beds, and we're able to maintain them with our hospitalists that are well-skilled in taking care of our postoperative deformity patients. And then again, this is the ISDS study group that looked at MIS compared to open. And again, what they showed is decreased blood loss but increased operative times. We actually showed decreased blood loss and decreased operative times using our technology or our approach. And then this was a case in which they did anterior column reconstruction, but then did an open case posteriorly, and you can see the difference, about 2 liters of blood loss, 7.3 hours of surgical time, as opposed to less time in the hospital, less blood loss, et cetera. And then Neil Anand, who published this data, which is probably closest to our data. The only real differential is that his hospital stay was 10 days as opposed to 5 days, and I attribute that to they had a longer interval between the 2 cases. So if I do the first stage on Monday, I typically do the next stage the next day. I feel that physiologically the patient is doing well. I would actually be nervous waiting the 3 days because a lot of times they've hit their physiological nadir at that 3 days post-op, so I take advantage of them still being beefed up from a physiological standpoint and just do them 1 day apart. And so lots of limitations. Obviously, this is a retrospective study, single surgeon, single institution, limited by follow-up secondary to COVID, et cetera. I'm just going to skip this other case study, but again, a similar patient that has prior fusion at L4-5 level. This is the slide that's most important here is, again, the concept of marginal gains. These patients don't come to us unscathed from medicine, et cetera. The things that we needed to do was optimization of this patient, so bone health optimization, et cetera. And then we were able to accomplish this. What I want to draw your attention to is the bottom of the construct. Removing that L4-5 hardware would have added an hour, hour and a half to the case. In this case, I could do a construct plan, which allowed me to leave the hardware in place and pass my rod directly past it. So in conclusion, this concept, this approach, adopting as many of these strategies for marginal gains seems to allow us at least what I call the democratization of deformity care. We can be a high-volume deformity practice at a non-academic institution by adopting these strategies to help the patient. And Rick already talked about these, so I'm not going to belabor these points, but the other uses of robotic technologies, we've utilized every single one of those that he mentioned as well. So.
Roland, really, really beautiful cases. Oh.
This is recorded.
Yeah, those are really beautiful cases. And the one question I had from a technical standpoint, because certainly it's been shown in terms of percutaneous T10 pelvis, when you went up to T4, how did you, because I saw your text, was it like you described sort of a mini open? Is it like a full open, or do you open up to the fascia?
All I'm doing is I dissect down to fascia. I clean off the fascia on both sides, and then do a subparacial dissection of the spinous process down to the spinolaminar line, usually on the convexity, because that side is presenting itself to me, so it's a little less deep a dissection. I move the muscle out of the way, use a high-speed burr, decorticate everything, and then put your biologic of choice in that area. I will do the percutaneous facet fusions with the robot, similar to what Rick taught us about from L1 to S1, but up above, that's my only biologic. And there's actually, one of those slides actually shows a fairly solid wall of that bone graft on the CT scan right there. See up above, that's what that biologic is.
That's beautiful, thank you.
Beautiful, but I'd like to know, when do you draw the line between a case you can tackle with your robotic technique and the case where you feel you cannot do robotic? Where do you draw this line?
So to be honest, a lot of it is drawn intraoperatively, to tell you the truth. So we always approach most of these cases with the idea that we're going to be able to accomplish this. Now, I learn a lot from that CT scan on the intraoperative stage, and I have converted some from a minimally invasive posterior approach to something that I need to do, more osteotomies to get better sagittal balance correction, et cetera. So that's obviously done before the second stage. But, you know, what I look a lot of times is I'll drop my rods. Dr. Anand at the lateral course just a couple months ago gave an amazing description of pretty much exactly how we do our sequential tightening of the set screws to derotate the spine when you're not looking at the spine. And I'm always somewhat amazed at how good it turns out. In the cases it does not turn out well, then often that's going to open up and become a mini open procedure in which I have to do some sort of osteotomy with either compression or distraction to get better coronal fixation. That's usually the same time that I decide whether to do a kickstand or not. And so that patient that I used as the sentinel patient here was a kickstanded patient that we decided when we had not enough correction of the coronal imbalance, we used the kickstand to push it back over at the end of the case, essentially. But that's also put in percutaneously. So.
Roland, do you do any derotation? And if you do, are you able to do it percutaneously? Are you able to extend it through the towers?
Yeah, so again, back to this technique. You pass the rods, right? And so they're all captured. And what we're going to do is we're going to sequentially tighten the set screws, starting with the apex of the concavity of the deformity. What I don't like to do is lock any of the set screws. We control the rotation of the rod by the rod introducers, right? So I keep them normal to the floor so that the rod is not just rotating with the deformity. And that's where my PA is involved. But we sit there and we'll sequentially tighten the screws. And that's why I attribute to no screw pullout is the idea that we're load sharing between 4 or 5 pedicle screws across the concavity of the deformity to allow for derotation of the spine. Does that make sense? So, you know, the other rod is sort of neutralizing everything, and then we're derotating through the concavity. So if we have a, say, left-sided concavity in the thoracic spine, I'm going to tighten that first. Right-sided concavity in the lumbar spine, I'm going to tighten that first. And it derotates the spine to that. And then as soon as I'm happy with that, the first ones that I'll lock in are my most proximal screws to lock rotation, and then I'll final tighten all the way down.